Good afternoon. It's a pleasure to be here. Thank you, Peter, and the organizing committee for inviting me. So since this is the last session of the day, and I think anyone who knows me can guess what's going to come next after we go through my disclosures. These are my disclosures for everyone to review for a moment. And these are the learning objectives. So what I'm hoping to accomplish in our short time together is an explanation of how the utilization of outpatient dialysis for AKI has really evolved quite significantly in the last couple years. Talk about the clinical outcomes of this very important, and I would argue understudied population. And then last, to describe some of the clinical characteristics of this unique population. So this is just a brief outline of what I'm hoping to cover in our time together. We'll talk a little bit about the incidence of AKI-D, the policy as it relates to outpatient treatment of AKI, the limited literature that exists today. We'll talk about our experience as a large dialysis organization with AKI treated in an outpatient setting, and then also look at Medicare beneficiaries with AKI requiring dialysis that's been managed on an outpatient setting. So this is what everyone who knows me could anticipate. It's late in the day, so we'll try and make this somewhat interactive for the audience. So the first question is this. In 2017, the first year policy changed as it relates to outpatient treatment for AKI. What was the approximate number of Medicare beneficiaries who received outpatient treatment? 3,000, 6,000, 9,000, or 12,000? I think they'll do the polling. Okay, has everyone voted? We'll go on. Pretty good guesses. Oh, the numbers are changing. I'll give it one more minute. All right, so we all went to medical school, so we all love B or C. So the correct answer in this case was 9,000. And many of you may have estimated lower numbers because I will tell you this far exceeded projections based on the number of treatments that likely were anticipated when this Medicare policy shifted. So the next question is this. Among patients who initiate outpatient dialysis for AKI, so they transfer to an outpatient setting, what percent would you expect to recover kidney function in the first 90 days of outpatient dialysis? So 15 to 25%, 30 to 40%, or 50 to 60%? I'm going to give this one a minute because I think these numbers are going to shift a little bit as more people vote. Okay, so impressive. So the vast majority got this one right. It's 30 to 40%. We'll talk about some of the literature that's been published, and then I'm also going to present findings we presented at ASN last year. And then this is the last question, and this is a little bit tricky unless you happen to buy one of the ASN posters, but I think it's worth us thinking about in advance, which is in the 6 months preceding the initiation of outpatient dialysis for AKI, what is your best guess as to the average number of days Medicare beneficiaries are spending in the hospital for those in that 6-month period? And the choices are 12, 27, 33, or 41 days. Okay, again, this group, I think, already knows all the answers. So hopefully I'll share something with you all today that you don't already know, but it is 27 days, which again, is just meant to emphasize, as all of the practicing nephrologists in the room know, many of the patients being managed now on an outpatient basis for AKI have likely had very serious clinical sequelae that precede the development of AKI requiring dialysis and have had prolonged time in the hospital. And we'll really try and talk about some of the clinical characteristics of this population because I think it helps us think about where we need to focus our research efforts and our treatment strategies and management. So I think many of you are familiar with multiple studies now showing the increasing incidence of AKI requiring dialysis. So Sue and colleagues published this a number of years ago, and then more recently a study was published to update trends in AKI requiring dialysis. And in the most recent study published in AKI-D in December, it was stratified by whether individuals did or did not have diabetes. So among individuals with diabetes, there's been a 56% increase in the incidence of AKI requiring dialysis between 2000 to 2015. Whereas in individuals without diabetes, that increase was predominantly seen between 2000 to 2009, where there was a 72% increase, but there was a subsequent plateauing. But I think there's pretty convincing evidence that we've continued to see increased incidence in AKI requiring dialysis, so the most severe form. This has also been shown in ICU populations, where there's been a significant increase in the incidence of AKI requiring dialysis in ICU populations. Simultaneously, in these same studies, there's been an examination of mortality associated with AKI, and it has been consistently shown that it appears that mortality in this population is declining, whether you look at that in hospitalized patients or more specific subpopulations like the ICU population. And that in the most recent study, there was a 2 to 4% annual decline of in-hospital mortality between 2000 to 2015. There are multiple theories about why this might be, but it does seem pretty consistent across most studies. And so I think it's important for us to recognize that there's an increasing incidence of AKI requiring dialysis, and at the same time, a decreasing mortality, potentially resulting in a larger population that's going to need prolonged dialysis for the management and treatment of AKI. These estimates of what percentage of patients will require dialysis at the time of discharge, specifically to support AKI, predate policy changes. And I think these really are rough estimates that I suspect will evolve in coming years. But it's been previously estimated that somewhere between 10 to 30% of patients with AKI who survive the hospitalization, which they develop AKI, will still need dialysis at the time they leave the hospital. But as many of you know, prior to 2017, the management of AKI in the outpatient setting was highly complicated, and it really depended on a number of factors, including the payer, state regulations, outpatient dialysis policies and procedures, whether hospitals had contractual care arrangements, or whether there was a hospital-based outpatient facility. And so prior to 2017, the management of AKI happened quite differently throughout the country, depending on where someone resided and the resources available in that local area. However, in January of 2017, CMS implemented a policy that allowed Medicare beneficiaries with AKI to be treated in outpatient ESRD facilities. And so, as you know, AKI in of itself is not an entitlement for Medicare. It does not parallel ESRD, but if a Medicare beneficiary developed AKI, then they could receive care in an outpatient ESRD facility. And I think this really heralded a major shift in management of this population, which we'll go on to show you. So this is some of the literature that exists on the management of AKI in the outpatient setting prior to 2017. So these are primarily single center or single health system studies, and I've listed 3 of them for you because the University of Michigan, University of Virginia, and the Mayo Clinic health systems have published their experience with managing AKI on an outpatient basis. You can tell these retrospective cohorts occurred over different time frames, so just to walk through each of these. The University of Michigan cohort was from 2013 to 2015. It included individuals who had AKI requiring dialysis at the time of hospital discharge. And outpatient dialysis was provided at a hospital-based dialysis facility, and the focus of this study was 90-day outcomes. The University of Virginia also looked at patients they had cared for who required dialysis at the time of hospital discharge, or patients who were referred to their therapeutic extracorporeal care unit. So it was a combination of patients from their health systems and surrounding ones. And all of the outpatient dialysis in this study was provided at the TECU, and the focus was primarily on the 3-month outcomes of this population. Last was the Mayo Clinic Health System, and this is a study that looked at patients between 2006 to 2009, and it was a little bit different because they were focused on patients who initiated hemodialysis in the hospital and then went to outpatient facilities. So this included AKI, AKI superimposed on CKD, stage 5 CKD, and acuity unknown in terms of their kidney failure. And patients were treated at 8 outpatient dialysis facilities in this study, and the focus was primarily on 6-month outcomes. For the purposes of our discussion, I'm really just going to focus on those who had AKI or AKI superimposed on CKD, because that's the population we're most interested in for today's discussion. And what you can see as I just try and summarize the major outcomes across these studies is that both in the University of Michigan and University of Virginia study, a large proportion of individuals recovered kidney function, 42 to 43%. Now, nearly 45 to 50% went on to transition to end-stage kidney disease. But this was the first signal in my mind that recovery of kidney function, even in sustained AKI requiring outpatient dialysis, was possible. And not only possible, but even probable in some populations. Now, recovery of kidney function was less likely in the Mayo experience. Around 24% of patients recovered kidney function at 6 months, but some of these differences across studies may relate to the underlying populations. I think it still signals to us the importance of thinking about recovery of kidney function when individuals are managed on an outpatient basis for AKI. So now I'm going to transition just talking a little bit about our experience at Fresenius. So this will be the experience of a single large dialysis organization with management of AKI since changes in policy really heralded, I don't know if I'm saying that correctly, a shift in care, I would say. So what we did for this cohort is we took all individuals who were adults and initiated outpatient dialysis for AKI within an FMCNA outpatient facility between May 2017 and December 2018. Now, to be included in the cohort that I'm going to go on to show you data from, the admission for in-center HD had to exceed 7 days. So this resulted in more than 15,000 individuals with AKI admitted on an outpatient basis. And this graph is simply meant to show you the geographic distribution of the cohort and to show that really AKI was being treated throughout the US on an outpatient basis during this time frame, probably quite different than what you would have seen prior to 2017. And then this simply looks at counts. What you can see is in 2017, there were more than 600 admissions per month for AKI requiring dialysis as an outpatient. And then by 2018, the numbers started to range more between 750 to 900 admissions per month. And if you look at the baseline characteristics of this cohort, it's probably to some extent what you would expect. The average age is 64, but there is a broad distribution of age, and you can see there are many young adults developing AKI requiring outpatient treatment. 41% of the cohort was female. So this is the initial dialysis prescription. And I intentionally included this figure because I think it really saliently drives home the point. The vast majority of patients with AKI are being prescribed thrice weekly dialysis, around 97%, with a mean treatment duration of 223 minutes or a median treatment duration of 240 minutes. Now, if we next look at how long are patients being treated for AKI, so this is really treatment duration for AKI. So this is prior to recovery of kidney function or transition to end-stage kidney disease, death, end of follow-up, or loss to follow-up. And the median treatment time is about 45 days. If we then go on to look at outcomes, and specifically the question is looking at the earliest of these 3 outcomes, what you see is at 13 weeks, or approximately 3 months, 44% of individuals have transitioned to end-stage kidney disease, 38% have recovered kidney function, and nearly 10% have died. So to just briefly recap the experience, at least in a single LDO, more than 15,000 patients in this 20-month period were admitted for management of AKI. And this wasn't one of my questions, but maybe I should stop here and just ask, again, trying to make this somewhat interactive, how many people are surprised by this number? Yeah, really? None of the rest of you are surprised? I think this number may have been a lot higher than people would have anticipated because, again, this is just a single LDO's experience. We'll talk about Medicare beneficiaries. It's clear the Medicare experience is higher than was anticipated. And so I find this in of itself to be important for us to understand how many patients are starting to change care settings for the management of sustained AKI and really what that means for us in terms of optimizing therapy and ensuring recovery of kidney function whenever it's possible, and alternatively, optimizing the transition to end-stage kidney disease when recovery is not possible. It's clear that AKI is now being treated throughout the US and on an outpatient basis. And importantly, within 3 months, nearly 40% of patients are recovering enough kidney function to stop dialysis, at least for now. So another line of research that Eric Weinhandel has been leading is really trying to better understand outpatient dialysis treatment for AKI-D among Medicare beneficiaries. So he created a cohort using Medicare limited data sets from 2014 to 2017, and because of the policy change, obviously focused only on calendar year 2017 to identify Medicare beneficiaries who were initiating outpatient dialysis. To be included in this cohort, you could not have any prior claims for end-stage kidney disease-related outpatient dialysis, which did identify patients that perhaps in 2014 or 2015 had had diagnoses of ESKD, presumably recovered, and then subsequently were diagnosed with AKI. So this resulted in a cohort of more than 9,000 Medicare beneficiaries for 2017. And this, again, is just to show you the geographic distribution, to give you a sense of the broad distribution of the cohort and Medicare beneficiaries receiving treatment for AKI on an outpatient basis. And these are the baseline characteristics, and there are just a couple things I'd like to point out. One, the cohort is not exclusively elderly because there are other reasons you can be entitled to Medicare, and so about 25% are under the age of 65, 56% are male, and 27% were dual enrolled in Medicare and Medicaid. If we look at the count of Medicare beneficiaries starting outpatient dialysis for AKI by month, you can see it ranges, it's around 750, but ranging from 700 to 800, except for in the latter part of the year in December, that number starts to increase. Now, we've only looked at 2017, so I can't tell you if that's an early harbinger of the trend to come, but generally it was around 750 per month. Now, looking at treatment duration is actually more challenging in the Medicare population when you're using claims because it's difficult to identify recovery of kidney function. You can easily identify transition to ESKD, you can identify patients who have died, but to identify recovery requires you to create some rules. So the rule that was created initially was no outpatient treatment for AKI for 2 weeks. Now all the nephrologists in the room are already thinking about all the reasons they don't like that definition, and we'll have some time during the panel to talk about definitions. But for now, that's the definition used for this. So if you don't receive outpatient treatment for AKI for 2 weeks, that is treated as if it is recovery of kidney function. And with that definition, the mean treatment time for AKI was 45 days, whereas the median was lower at 34. And to look at outcomes, again, we had to select a definition of what's recovery of kidney function. So the first graph I'm going to show you is assuming that no outpatient dialysis for AKI for 2 weeks equals recovery. If you make that assumption and look at the earliest of these 3 events, approximately 37% of patients recover kidney function within 3 months or 13 weeks, 36% transition to ESKD, and 10% die. If you create an alternative definition, because of course one of the concerns about definitions like 2 weeks is, well, what about prolonged hospitalizations or other things that may result in someone not receiving outpatient dialysis for a prolonged period of time? So if instead you select 4 weeks. Now, before we go through the numbers, I should say there are downsides to 4 weeks. I mentioned to you this is a cohort that's being formed in 2017. But the follow-up is also ending in 2017 because that's the length of the limited data set. So now people who are initiating dialysis later in the year, you're literally making it impossible for them to achieve this definition of 4 weeks without outpatient dialysis. So there are some trade-offs here. Neither is perfect, but it gives you an alternative view. So if you use this definition instead, what you can see is about 38% of individuals will transition to AKI-D. And I think okay, can you all hear me? At 13 weeks, 31% will recover kidney function, and approximately 13% will die. Now, on this slide, when we are talking about mortality, this is always the earliest of these 3 events, whether it's transition to ESKD, recovery of kidney function, or death. But if we ask the question differently, which is what is the cumulative mortality in this population, Medicare beneficiaries with AKI treated on an outpatient basis? And this looks at mortality even after you've recovered kidney function or after you've transitioned to ESKD. So this is truly cumulative mortality. What you can see is mortality is quite high in this population, 17% at 12 weeks and 25%, nearly 25% at 24 weeks. We thought it would be important and valuable if we tried to better characterize this Medicare population and really tried to look at the clinical course that precedes outpatient treatment for AKI. So we took that same cohort we've been talking about, and Eric further restricted it to those beneficiaries who had had at least 6 calendar months of Medicare coverage so that we could look at Medicare claims and try and derive additional information about this population. So that decreased the size of the cohort slightly to 8,500 individuals with Medicare. So the first thing that we evaluated were hospital admissions and hospital days in the 6 months before. And this was the question half of you already got correct, but I'll show you the data anyways. On average, these individuals are being hospitalized 2 times in that 6-month period, although the median number is 1. And the mean days spent in the hospital are 27. So I think everyone can appreciate that is not a trivial amount of hospital time in a 6-month period. And actually, the mean hospital days and the hospitalization that immediately precedes AKI is quite long, as has been shown in a number of other studies that have looked at this. I think it's also important to look at comorbidities and major clinical events that precede AKI. So this is taken from the diagnoses in the hospitalization that's immediately before you start outpatient treatment for AKI. And what you can see is more than 80% have a diagnosis of CKD, more than 50% have a diagnosis of diabetes or heart failure. There's in excess of 30% with diagnoses of atrial fibrillation. Acute respiratory failure is diagnosed in approximately, or nearly 30%, I should say, it's 29%, and sepsis in 20%. So I think this really gives you a sense of some of the clinical events, which I think we all know precede severe AKI, but it does help better understand the population and potentially their very substantive care needs in this post-hospital period. So just to briefly recap our discussion of Medicare beneficiaries, in 2017, more than 9,000 Medicare beneficiaries were treated on an outpatient basis for AKI requiring dialysis. And regardless of the definition you selected, within 3 months, more than 30% recovered kidney function. So again, a substantive proportion recover enough kidney function to stop dialysis. And the preceding hospitalization was frequently complicated by major clinical events, including acute respiratory failure and sepsis. So in conclusion, I think it's important to note that recovery of kidney function is common in this population. So more than a third will likely recover enough kidney function to discontinue dialysis, even when this has been sustained AKI in a prolonged hospital course and on an outpatient basis. I think given the increasing incidence, decreasing mortality, and clearly evolving care settings, we really, as a community, need to anticipate this population will likely continue to grow and need to be cared for on an outpatient basis. And at least from my perspective, significantly more research is needed for us to really understand how to optimize care in this population, not only to optimize the chances of recovery of kidney function, but when that's not possible, to ensure the best transition to dialysis or to transplant that's possible after the development of. So I will stop there, and thank you, everyone.